Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 157 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, RPD, a 23-year-old male university student presents to your accident and emergency department with a chief complaint of penile discharge, and burning on urination. He informs the emergency medicine physician on duty that he drank too much during the past weekend, about 6 days ago, and eventually indulged in unprotected intercourse with a woman he met at a party. He has no comorbidities. He currently takes no chronic medications. He has no known drug or food allergies. A physical examination is done, and a urethral discharge smear is obtained. The smear reveals moderate gram-negative diplococci and many polymorphonuclear cells. So my question to you is, which of the following would be the most appropriate treatment recommendation for RPD? Would it be A. doxycycline 100 mg taken orally twice daily for 1 week, or B. ceftriaxone 250 mg IM stat plus doxycycline 1 gram orally stat, or C. ceftriaxone 250 mg IM stat plus azithromycin 1 gram orally stat, or would it be D. ceftriaxone 250 mg IM stat? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. ceftriaxone 250 mg IM stat plus azithromycin 1 gram orally stat. The patient's clinical presentation and presence of gram-negative diplococci from a urethral smear are consistent with gonococcal infection. The recommended regimen for gonococcal infection is ceftriaxone 250 mg IM stat plus azithromycin 1 gram orally once. That makes answer C correct. Because of high co-infection rates, a patient with gonorrhea should also be treated for chlamydia, even if the chlamydia test is negative. In addition, treatment of chlamydia provides dual coverage against gonorrhea, which may prevent the development of drug resistance. That makes answer D incorrect. Tetracyclines may be used for chlamydia alone but are not recommended for gonococcal infections because of increased resistance, which makes answers B and A incorrect. Please advance to the next question. And the next question reads, WBM, a 22-year-old female patient presents to her gynecologist. She has a chief complaint of painful, ulcerative lesions on her labia bilaterally. A presumptive diagnosis of herpes labialis is made. As the clinical pharmacist specialist in the infectious diseases team, the gynecologist requests your opinion on WBM's treatment. So my question to you is, which of the options listed below would be the most appropriate therapy for WBM's first episode? Would it be A. Valganciclovir 900 mg orally once daily for 1 week, or B. Valacyclovir 1 gram orally thrice daily for 1 week, or C. Acyclovir 800 mg orally twice daily for 1 week, or would it be D. Acyclovir 400 mg orally thrice daily for 1 week? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Acyclovir 400 mg orally thrice daily for 1 week. For a first episode of herpes labialis, acyclovir 400 mg orally 3 times daily is a reasonable first-line option. That makes answer D correct. Increasing the acyclovir dose to 800 mg is unnecessary. That makes answer C incorrect. The correct valacyclovir dose for HSV is 1 gram orally twice daily, which makes answer B incorrect. Although valganciclovir is active against HSV, its spectrum of activity is broader than necessary. That makes answer A incorrect. Please advance to the next question. And the next question reads, ASV, a female patient comes to the clinic with a urinary tract infection, UTI. A urinary dipstick test is done. Results are positive for nitrite, leukocyte esterase, protein, and blood in the urine. You are asked by your rotation student to explain the patient's urinary dipstick test because the student is confused by the results. Specifically, the student asks which urine dipstick result, if positive, is most specific for diagnosing a UTI. So my question to you is, which of the following would be the best answer for ASV? Would it be A. positive for protein, or B. positive for blood, or C. nitrite positive, or would it be D. leukocyte esterase positive? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. nitrite positive. A positive nitrite test result indicates the presence of nitrate-reducing bacteria such as Escherichia coli, therefore, it would be most specific for a UTI. That makes answer C correct. Leukocyte esterase, hematuria, and proteinuria are not specific for a UTI. Although leukocyte esterase indicates the presence of WBCs in the urine, it could be a sign of inflammation in the urinary tract, making answer D incorrect. Hematuria and proteinuria could also be present in other disease states. That makes answers B and A incorrect. Kindly progress to the next question. And the next question reads, D.J.P., a 20-year-old female patient presents to your accident and emergency department with a chief complaint of a 2-day history of urinary frequency and burning. She noticed this morning that her urine was dark red. She admits to having unprotected sex with her workmate 48 hours ago. Her urine studies have the following results. Her urine is hazy, it is nitrite positive, leukocyte esterase positive, positive for protein, and positive for blood. A WBC count 10 times 10 power 3 cells per millimeter cubed is reported alongside 103 CFU per milliliter gram negative rods. Culture speciation and susceptibilities are pending. So my question to you is, considering D.J.P's clinical presentation and urine studies, which of the following would be the best therapeutic decision for D.J.P? Would it be A. Treatment is not necessary because the bacterial inocula are less than 105 CFU per milliliter, or B. treat her for gonococcal and chlamydial infections, or C. treat her for acute uncomplicated cystitis plus gonococcal and chlamydial infections, or would it be D. treat her for acute uncomplicated cystitis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. treat her for acute uncomplicated cystitis. The patient presents with signs and symptoms consistent with a UTI, therefore, she needs treatment for a UTI. That makes answer D correct. Although the patient could be at risk of gonorrhea and/or chlamydia because of having unprotected sex, she does not have vaginal discharge, and her symptom onset is within 3 days of sexual contact. The usual symptom onset in women takes up to 10 days. A gram stain or NAAT would need to be done by a clinician using a vaginal swab to determine whether she has gonorrhea or chlamydia before treatment is initiated. That makes answers B and C incorrect. Significant bacteriuria traditionally has been defined as bacterial counts greater than 105 CFU per milliliter of urine. Many clinicians, however, have challenged this statement as too general. Indeed, significant bacteriuria in patients with UTI symptoms may be defined as greater than 102 CFU per milliliter of urine, which makes answer A incorrect. Kindly proceed to the next slide. And the next question reads, BSA, a 6-year-old girl is brought to the clinic by the mother, with a chief complaint of a one-day history of a red left eye. She says that she could barely take her test today at school because her eye is itchy and watery, and it feels like something is in it. On physical examination, BSA is afebrile, and her left conjunctiva is red and inflamed. No foreign objects or visual changes are noted. A provisional diagnosis of conjunctivitis is made. So my question to you is, which of the following would be the best treatment for BSA's conjunctivitis? Would it be A. supportive care only, with warm and moist compresses as needed, or B. Ofloxacin 0.3%, 1 drop into the left eye once daily for 2 weeks, or C. Ketotifen 0.025%, 1 drop into the left eye twice daily for 1 week, or would it be D. Azithromycin 1%, 1 drop into the left eye twice daily for 2 days, followed by 1 drop once daily for 5 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Azithromycin 1%, 1 drop into the left eye twice daily for 2 days, followed by 1 drop once daily for 5 days. Although conjunctivitis can be caused by many factors, e.g., allergens, bacteria, and, more predominantly, viruses, this 7-year-old girl goes to school and has involvement of only one eye, therefore, she should automatically be treated with topical antibiotics. Azithromycin would cover the most likely organisms of Streptococcus pneumoniae and Haemophilus influenza, thus, azithromycin would be a good choice. That makes answer D correct. Antihistamines might help, but topical antibiotics are warranted in this case. Allergic conjunctivitis is typically bilateral and often associated with other allergy symptoms. That makes answer C incorrect. Ofloxacin would be a good choice, but it should be given 4 times daily and for only 7 days unless there is reinfection or persistent infection. That makes answer B incorrect. Supportive care would be good in addition to antibiotics, but this should not be the only treatment, which makes answer A incorrect. Let's advance to the next question. And the next question reads, JAM, a 17-year-old male patient presents to your infectious diseases clinic with a chief complaint of worsening nasal congestion, headache, and severe toothache. He has just completed a 10-day course of co-amoxiclav 2 grams / 125 milligrams orally twice daily for sinusitis. He says that his symptoms were better for a few days but then continued to worsen during the past 7 days. He states that he was fully adherent to his regimen and didn't skip any days. He has no known drug of food allergies. So my question to you is, which of the regimens listed below would be the most appropriate for JAM now? Would it be A. Moxifloxacin 400 mg once daily for 10 days, or B. Linezolid 600 mg orally twice daily for 10 days, or C. Azithromycin 500 mg once daily for 21 days, or would it be D. Amoxicillin 1 gram thrice daily for 3 weeks? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Moxifloxacin 400 mg once daily for 10 days. This patient is not responding to his current regimen of high-dose amoxicillin, clavulanate. According to the new guidelines, his medication should be changed to a respiratory fluoroquinolone such as moxifloxacin, and because the patient's first-line therapy has failed, treatment would be extended to 7 to 10 days. That makes answer A correct. Amoxicillin is no longer recommended for sinusitis because of resistance. That makes answer D incorrect. Respiratory fluoroquinolones are preferred to macrolides for sinusitis. That makes answer B incorrect. Linezolid would not cover the possibility of infections with gram-negative pathogens, e.g., Haemophilus influenza or Moraxella catarrhalis, and its adverse effects and cost would be problems, which makes answer B incorrect. Please advance to the next question. And the next question reads, RQT, a 14-year-old male adolescent patient presents to your pediatric accident and emergency department with a chief complaint of a 4-day history of severe sore throat and a temperature of 38.3 degrees Celsius. He states he can barely swallow because his throat hurts so badly. On physical examination, RQT's tonsils are erythematous and swollen and he weighs 41.2 kg. A throat swab is taken, and the rapid antigen detection test, abbreviated as RADT, returns positive for Streptococcus pyogenes. He has no known drug or food allergies, so my question to you is, which of the treatment recommendations listed below would be the most appropriate for RQT? Would it be A. Cotrimoxazole 1 double-strength tablet orally twice daily for 10 days, or B. Penicillin benzathine 1.2 million units IM stat, or C. Penicillin benzathine 0.6 million units IM stat, or would it be D. No antibiotics are necessary? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Penicillin benzathine 1.2 million units IM stat. Penicillin is the treatment of choice for Group A streptococcus, thus, an intramuscular shot of benzathine penicillin would be appropriate. The patient weighs more than 27 kilograms, thus, the adult dose of 1.2 million units would be needed. That makes answer B correct. The patient has a positive strep antigen test result, thus, treatment with antibiotic therapy is necessary. That makes answer D incorrect. The patient weighs more than 27 kilograms, hence, the pediatric dose of 0.6 million units would be insufficient. That makes answer C incorrect. Group A streptococcus is resistant to cotrimoxazole, therefore, this antibiotic choice is inappropriate, which makes answer A incorrect. Please proceed to the next question. And the next question reads, TMC, a 50-year-old female patient presents to the clinic for a routine follow-up. Her surgical history is significant for being a renal transplant recipient. She has no known drug or food allergies. Her allograft is functioning well, and she has not been treated for rejection. So my question to you is, because the influenza season has just begun, which is the most appropriate means of prevention for TMC? Is it A. Oseltamivir 75 mg orally once daily for the entire duration of the influenza season, or B. Live attenuated influenza vaccine, abbreviated as LAIV intranasally once, or C. Inactivated influenza vaccine, abbreviated as IIV intramuscularly stat and Oseltamivir 75 mg orally once daily for 14 days, or is it D. Inactivated influenza vaccine, IIV-IM stat? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Inactivated influenza vaccine, IIV-IM stat. Vaccination is the most effective method for preventing influenza. The inactivated vaccine is preferred over the live vaccine for this patient because she is a transplant recipient and because the live vaccine is no longer recommended. That makes answer D correct and answer B incorrect. Use of Oseltamivir for 2 weeks at the time of influenza vaccination to provide protection until immunity from the vaccine is established may be considered if a patient has an influenza exposure. That makes answer C incorrect. Vaccinating is preferred to administering Oseltamivir to prevent influenza. That makes answer A incorrect. Please advance to the next slide. And the next question reads, MJM, a 67-year-old female patient presents to her personal physician for an annual follow-up. She states that she cannot recall ever having chickenpox or shingles. So my question to you is, which of the options listed below would be the best to prevent herpes zoster in MJM's case? Would it be A. Obtain assay for varicella zoster virus, abbreviated as VZV immunoglobulin G, and if negative result, give Varivax, if positive result, give Zostavax, or B. Administer Zostavax, or C. Administer Varivax, or would it be D. Administer varicella zoster immune globulin, abbreviated as VARIZIG? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Administer Zostavax. The ACIP guidelines recommend a one-time dose of Zostavax to all individuals 60 and older, regardless of herpes zoster history. That makes answer B correct. Thus, this patient does not need VZV serologic testing. That makes answer A incorrect. Varivax is recommended as a routine childhood vaccine and may be given to certain immunocompromised patients who are VZV negative. That makes answer C incorrect. The VARIZIG is recommended only as PEP in high-risk VZV negative patients, which makes answer D incorrect. Please advance to the next question. And the next question reads, TPT, a 42-year-old male patient living with HIV infection presents to your pharmacy seeking information about available pneumococcal vaccines. 5 years ago TPT received 1 dose of pneumococcal polysaccharide vaccine, abbreviated as PPSV23. So my question to you is, which of the pneumococcal vaccines listed below would be the most appropriate for TPT today? Would it be A. Neither vaccine is recommended, or B. Either vaccine is appropriate, or C. Give 1 dose of pneumococcal polysaccharide vaccine, abbreviated as PPSV23, or would it be D. Give 1 dose of pneumococcal conjugate vaccine, abbreviated as PCV13? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Give 1 dose of pneumococcal conjugate vaccine, abbreviated as PCV13. This patient with HIV infection is considered an immunocompromised person. This makes him a candidate for both PCV13 and PPSV23. Although the patient has already received the first dose of PPSV23, he should receive 1 dose of PCV13 now and then 1 dose of PPSV23 at least 8 weeks after receiving the dose of PCV13. The patient will be eligible for a 3rd dose of PPSV23 at age 65. That makes answer D correct and answers A to C incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 158.